Eddie reporting from the Denver VA on nights,
Wow.
even though I didn't think the time difference was so great between Mountain Time and Central Time. Um, Harry's going to be doing teaching points and Sasa and scribing, um, and we have Noah and Marcelo, is it? Um, Hanging out making pizza. So it's a great day to hear a case from Maddie and uh, have some fun and maybe learn a couple of things. Anything else anyone wants to share before we get started?
Excited to see everyone.
All right, should I jump in?
Let's do it.
Go for it.
Okay, so just to kind of paint the setting, so this was when I was on MICU, and our team was called to come to the emergency department to come evaluate a patient with labs that were notable for a lactate of 19 and an anion gap of greater than 39. And I will pause there.
It's too many lactates.
There's way too many lactates.
Mm.
You know, the first thing that kind of came to mind was the question of, is the anion gap of 39 explained entirely by the lactate of 19? What do you think, Steph?
I think it could be.
I think so too. Um, but recently this comes up a lot, like, and I think it's trickiest in my experience um, with beta hydroxybutyrate, actually. Because with beta hydroxybutyrate, you can have an anion gap of, 30, and you check a beta and it's 6. Um, and I used to sort of wonder again whether the kind of units are equivalent, whether each molecule of beta hydroxybutyrate is one anion, and thus 6 would explain an anion gap of 16, but not 30. And we had more to explain with the anion gap. Um, and the answer in the setting of ketones is that it's not just beta hydroxybutyrate. There's other unmeasured ketones, acetoacetate, and others, as well as kind of how there's not a single sort of kind of anionic charge-based 1-for-1 ratio with some molecules. But anyway, I think I would be open at this point to kind of make sure we're not missing another anion. But a lactic acidosis of 19 is, I don't know if I've seen a higher lactate level. So definitely the main problem to be solved has been recharacterized from, elevated anion gap to elevated lactate.
Yeah. I think everyone's attention first would be to figure out where the lactic acidosis is from, which I'll quickly sort of comment about the way I think of that in a minute. But to Zavin's point, once you're done sort of opening your schema for lactic acidosis, running otherwise your anion gap metabolic acidosis, and people have various schemas, mnemonics. I'm not usually a major mnemonic user in terms of sort of alphabetical, but for whatever reason, I once learned the 21st century mnemonic for anion gap metabolic acidosis as gold mark. And I have used that ever since, as opposed to maybe the 20th century muck piles. Muck piles, as you guys know, is methanol, uremia, ketosis. P is paraldehyde, right? Like sort of a preservative. This is where this starts to fall apart as not necessarily something we see frequently. I is, help me, I'm having a brain fart. INH and iron toxicity, so excessive intake of those. L is lactate, E is ethylene glycol, S is salicylate. But gold mark, G is glycols, which includes all of those volatile alcohols other than ethanol. O is oxyproline, so that's an acetaminophen metabolite that even in non-toxic doses of acetaminophen can build up and cause a low-grade anion-gap metabolic acidosis. L is lactate, D is D-lactate. So the other lactate isomer that develops in short gut, et cetera, that a standard lactic assay won't pick up. And M is methanol, A is aspirin, R is renal dysfunction, and K is ketosis, right? Which comes in diabetic, alcoholic, and starvation varieties. So that's gold mark. But again, we've got our lactate here. We'll probably get a chance to chat more about it. But the big thing I'm sure you wondered right away, Maddie, when you got this call is this person hemodynamically stable or not? Because the very first division, and we'll get a little more story before maybe we unpack the lactate schema more, is this a hypoperfusion either globally or tissue ischemia specific? Or is this a lactic acidosis because anaerobic metabolism for various reasons is happening in the body, but perfusion is actually fine? So I'm sure the immediate thing you said is vital signs, please. So maybe you could give us a little more and then we can kind of get more into lactate if you want.
Actually, can I feel like we've been like pitching back to each other and like refusing to talk about
talk
the
over
lactate
like
for a long time, but that's what Maddie asks us to do. So
fair enough.
So okay, so between type A, hypoperfusion leading to anaerobic metabolism, lactic acidosis, and type B, the perfusion is fine, but there's another reason for anaerobic metabolism and lactate production. If y'all had to guess, and I'd love for as many people as possible to write in the chat here, do you think this is type A hypoperfusive lactic acidosis or type B metabolic poisoning of some kind, lactic acidosis? Go ahead, A or B? Both, Austin. What a cop out. Both happen in sepsis, by the way. Okay, we don't have that
tied.
many. We don't have that many votes. That's okay. I would bet a lot of money this is type B. Why? Because first of all, I've never seen ischemic hypoperfusive type A lactic acidosis cause a lactate of 19 because before the lactate is 19, you're not alive. And a chief complaint in a type A lactic acidosis isn't the lactate is 19. Usually it's the pressure is 60/40. So the fact that Maddie got called not for hypotension and shock, but for a lactate of 19 is why I would play that betting game. So that's all I'll say about that. Is that enough, Maddie, or do you want us to keep talking about the labs?
That is definitely enough. That was such an awesome discussion. I love kind of the prediction game. It will be cool to kind of see how your prediction plays out. That was awesome discussion.
I think that's code for I'm wrong, but it's fine.
I'm just not gonna just go to Alpha too.
Okay.
All right. So, went down there, and chatted with him to see kind of what brought him in, what his vitals were. So starting with the HPI, so he's a 33-year-old man, and he actually called EMS from home because of overall not feeling well. That was the words. I just have not been feeling well. And that had been going on for the past 2 weeks. And so I asked him, this has been going on for 2 weeks. Like, what made you kind of call EMS today? And he said that he called EMS this morning because he had such low energy and was feeling too weak to walk around the house. When asked kind of what else he had been going on these past 2 weeks, he said he has been feeling nauseous and has had non-bloody emesis and has vomited about once every 2 days for the past few weeks. I kind of asked if this is new for him, and he said this is actually not atypical for him. When further, tried to get a little bit more of the story about the past 2 weeks, he says that he's not eaten food for the last 2 weeks because he's not felt like eating, but he does have access to food and to water. He also has not slept in 3 to 4 days. And during
Wow.
this period, he has used methamphetamine and alcohol and last drank alcohol the day before admission. For review of systems, during this time has had this kind of intermittent abdominal pain associated with the nausea, but has not had any chest pain or difficulty breathing. He's not noticed any blood in his vomit or his stool, no diarrhea. For his past medical history, looking through his chart, he has a history of severe alcohol use disorder with a history of withdrawal and with seizures. Looking back through his chart, he had several hospital admissions for alcohol withdrawal. Also has a history of alcohol-associated hepatitis and a history of pancreatitis attributed to alcohol. He does not take any daily medications or supplements, no relevant family history, social history. So he lives with 3 roommates in Denver. He's not currently working, no recent travel. And for his health-related behaviors, so he drinks a handle of vodka every 2 days. As I mentioned, last drank the day before admission. He uses methamphetamines monthly, smokes 2 to 3 cigarettes per day for about the past 7 years. No IV drug use. He's sexually active with 1 male partner and has had only one male partner in the last like 6 months. And then for vitals and physical exam, which is, I'll give this to you and then we'll pause there. Of course, we looked at his vitals, before we went down, but he was afebrile. His heart rate was in the 140s. Blood pressure was 110/76. Respiratory rate was 18, and he was satting well on room air. So when I went down to see him in the emergency department, he was very ill appearing and appeared quite disheveled. He was lethargic, he appeared diaphoretic, and he was, fully alert, but kind of like appeared sleepy and was like intermittently answering questions. He appeared tremulous as well. There were no tongue fasciculations or asterixis, though. For his HEENT, what was notable is there was kind of a dark, grainy substance around his lips. And when I kind of asked him to open his mouth, shined a light inside his mouth, there was no obvious like red blood, but this dark, grainy substance was on the lips and then also dried on the tongue. For listening to his heart, it was tachycardic. There were no murmurs. For his lungs, he, actually did not appear in respiratory distress, had normal work of breathing. Lung sounds were clear. His abdomen, his vital sounds were present. It was non-tender. There was no ascites that I could appreciate. His extremities did not have any rashes or edema. And the neuro exam was completely normal, and just kind of the mild tremor that I noticed. And I'll pause there.
Wow, what a just great history. Just his baseline kind of symptoms he's had, the sort of subacute nature of the syndrome, and then importantly, kind of a lot of his social and living factors are so helpful.
That was also just a great exam, Maddie. A lot of important details, both positive and negative.
Just to have a roadmap, I think there's a lot to discuss here. Maybe I think we should unpack the lactic acidosis differential more. But one thing I actually want to ask you, Zaven, is this it's sort of a chicken and the egg question of this 2 weeks of nausea, vomiting, not feeling well. What do you think in terms of wondering if that was because the severe metabolic acidosis had been going on versus symptoms of the problem that then drove it? I guess I want to make the point of like making sure people know like what are the symptoms of a bad acidosis? And do you think his 2 weeks of symptoms could be a sign that this has been going on a while?
It's a great question. And actually, I don't know if I have the answer to that. People like when I'm thinking about the sort of vignettes, snapshots of people with severe metabolic acidosis First of all, a young, healthy person like this, I actually don't believe that his respiratory rate was 18. That might have been what's documented, but if his anion gap was really 39, if his lactate was 19, his serum bicarb was, I don't know, let's give him some concurrent metabolic alkalosis from the vomiting and a volume depletion, and let's call his serum bicarb 15 generously, but I wouldn't be surprised if it was 8, right? This young person with good muscles and good lungs is hyperventilating. Their minute ventilation is probably, 10, 12, 15 liters. Their PCO2 is probably, 28, if not 18. So they're going to compensate, and their pH probably isn't 7.1. It might be 7.2, 7.25, regardless. So metabolic acidosis and acidemia, other than potentially causing some dyspnea from that respiratory drive that you may or may not meet well, I don't think of any specific symptoms that result from that. That's in contrast to metabolic alkalosis and alkalemia, which definitely makes people feel crappy, right? So in alkalemia, you have ionized hypocalcemia, you have tingliness and anxiety, you have cerebral vasoconstriction, you might feel dizzy or lightheaded or unwell. But lactic acidosis itself, I'm not sure that it causes symptoms. Unlike, for example, ketosis, which, by the way, now that I hear this history, I do think there's a little bit of ketones mixed in there too. With that anion gap of 39, that's a little disproportionate to the lactate. But anyway, ketosis itself can cause nausea, vomiting, belly pain, where to me, that's a little bit more of a chicken egg situation. So I think in this case, I can think of, and I know you too, Steph, where this history, both of the alcohol use as well as the nausea, vomiting, malnutrition, I think there's a sort of a clearer directionality of that potentially leading to processes that can cause lactic acidosis rather than the other way around.
Cool.
Are you thinking the same?
Yes, but I just thought those symptoms, right? You got a great history of 2 weeks of symptoms, and that chicken and the egg question came to mind.
And we also have other potential explanations of those symptoms, which is that, drinking a handle of distilled spirits every 2 days, that's 2 liters of vodka per day. That's 800 cc's of pure ethanol per day. That is just absolute, like, it just wreaks havoc on your gut. I mean, many of us have had a couple of extra drinks and felt a fraction of, what could be going on in this guy in terms of just both the neurotoxic and directly enterotoxic effects of ethanol that can cause these symptoms. So yeah.
So lactic acidosis, let's start sort of really hammering out what causes it and compare it to the history we have. We talked about type A, hyperperfusion. To be very specific, it's total body shock, which even with the tachycardia this gentleman has, that's not what's going on. He's awake, he's alert, his blood pressure is systolic in the 110s. But type A includes shock, and then it includes regional tissue ischemia. And that can be from mesenteric ischemia. It can be from necrotizing soft tissue infections. It can be from limb ischemia, from critical acute claudication. So it's either shock or regional ischemia leading to dying tissue for type A lactic acidosis. Type B lactic acidosis, again, is essentially mitochondrial dysfunction or poisoning. Includes toxins and meds, and we've heard in his history toxins that are on the list. Alcohol can lead to lactic acidosis to this degree. I don't think that would be the main explanation, but it is a trigger. Other substance use, I don't know specifically about methamphetamine. I would imagine it probably could, but someone can look that up. But certainly cocaine, other illicit substances can do it. So that is absolutely a potential trigger for him. Liver dysfunction and the inability to clear the lactate is on the list. Again, would not drive it to 19, but in this person who has a history of alcoholic hepatitis, may have some chronic dysfunction, that is a trigger. So drugs and toxins, liver dysfunction, and then meds we prescribe. So I think we've all learned metformin can do it. It's very rare, and it's usually in very advanced kidney injury, not relevant in this case, but important. But there's other meds that can do it also. Tylenol in high doses, certain antiretroviral medications, which he's not on, I think specifically protease inhibitors. So pharmacologic meds we prescribe are on the list. I have not given a comprehensive set, but again, we don't know that he's taken any of those. Malignancy, where the burden of tumor is so much that anaerobic metabolism is happening within the tumor, also known as Warburg effect, can cause a lactic acidosis. To this degree, again, no. And we don't really have a sign that we should be super worried about occult aggressive lymphoma or anything in this guy, but it's on the list. And underlying like mitochondrial dysfunction from primary congenital disorders. Again, I don't think this guy would be at risk for it. And then I think important consideration for him for a couple of reasons is thiamine deficiency, which, boy, I have to go way back to kind of the Krebs cycle, but it's an important agent when it comes into the handling of NAD and NADH in actual mobilization of glucose. And thiamine deficiency is a real risk for this guy. The alcohol use, the lack of oral intake, and then he's manifesting some neurologic signs and symptoms now that we just need to figure out. The tremor certainly could be from early withdrawal, but is there underlying kind of other signs of profound thiamine deficiency, which can cause lactic acidosis as well? Anything else you want to add to the type B list? So it's drugs, toxins, meds we prescribe, liver dysfunction, mitochondrial disease, malignancy, high burden, thiamine deficiency.
I would just add to the list of drugs that I think we see probably most commonly is sympathomimetic, specifically like high dose or continuous albuterol inhalation or epinephrine infusions in the ICU. And what both of those have in common is beta 2 stimulation, which at a mitochondrial level also shifts the metabolism towards anaerobic metabolism. And that also helps you sort of think about some of the illicit substances that people use. So cocaine, methamphetamines are both sympathomimetics, right? So cocaine is a norepinephrine, and I actually, I guess I don't know if it's also an epinephrine reuptake inhibitor, but I would guess so, and that may be the mechanism why those drugs could be contributing. But yeah, and then on the cancer topic, I don't know if I've seen 19, but I've seen double-digit lactates for sure from Warburg effect. And when I first heard that chief complaint, and then you opened with 33-year-old man, my first thought was actually it was lymphoma. But obviously it's not the case anymore. Yeah, I think and to go back to Austin early on saying his bet is both. That's generally my bet too. I think in a lot of cases there's a lot of things contributing, but in this case, actually would guess that it's not as much like hypoperfusion, like type A and type B. I would probably guess it's multiple type Bs, as well as just or specifically a component, Steph, of so thiamine deficiency, some of those substances, and then maybe some liver dysfunction, in the background, where whatever lactate he's making is less likely to be converted to pyruvate and excreted, et cetera, and sort of resulting in higher accumulation. But
two final quick comments. The dark grainy substance on the lips, just love that you picked that up and it's there. I don't know what it is. I saw some thoughts in the chat. Is it old dried blood? Great thought. Is it related to something that he ate or ingested? Maybe. Generally in this malnourished guy, like the specter of just other vitamin deficiencies is out there. It doesn't sound like you're describing angular cheilitis or the rash of zinc deficiency, but I don't know what it is, but I wonder if it's ingestion related, blood related, deficiency related. The only other thing before the next aliquot is I don't think the metabolic disarray is going to end with his mixed acid-base status. And I like Zaven's point that it's probably, if we did all the math with his pH and his GAP, probably going to have multiple primary acid-base disorders going on. But again, in this person with a lot of alcohol, not a lot of nutritional intake, I suspect we're going to run into a lot of metabolic disarray with hypokalemia, hypomag, hypophos, maybe not on day 1, but maybe on day 2 as his acidosis corrects, will the picture kind of complicate in terms of other electrolyte issues. But Maddie, feel free to give us more.
Right. That was absolutely brilliant. I loved your breakdown of the lactic acidosis and kind of the chicken and egg question and a lot of the thoughts that I was thinking as well. So I will give you some of the initial labs. So the VBG showed a pH of 7, a PCO2 of 18, and a bicarb of 5. For his basic metabolic panel, he had a sodium of 136, potassium of 3.4, chloride of 87, bicarb of less than 10, BUN of 11, creatinine of 0.99, and the anion gap of greater than 39, as I mentioned. Initially, his FOS was 5.7 and his MAG was 1.8. A CBC, the first one that we got, had a white count of 16, hemoglobin of 14, platelets of 196. For liver enzymes, the total Billy was 2 with a direct of 1.2, AST 260, ALT 109, ALK-Phos 309, and an INR of 1.4. His lactate was initially 19, and then after receiving 2 liters of volume resuscitation, it downtrended to 16. An ethyl alcohol level was elevated at 166, normal being less than 10. Salicylates were negative, lipase was normal, troponin was normal, a CK was normal, a beta hydroxybutyrate was 58.5. And the urinalysis was notable for 1+ ketones. And that was the most notable finding on the urinalysis.
That the units of the beta, can you clarify that, Maddie? I'm guessing it's per liter rather than per deciliter or something.
I can pull that up. I didn't write down the liters, but or the units, but it
Or
was
just
quite
a normal
elevated. But
value is
I will pull up the units,
20.
but it was
Yeah,
elevated.
I think yeah, it's I think like our lab like normal is less than 0.2 or something like that, and I just want to kind of get a sense of the scale of that. But
Let me check.
Wowski. Okay, so I stand corrected about the pH, and yeah, I mean the overwhelming kind of amount of accumulated anions, that gap of 39, I guess even with some metabolic alkalosis, the bicarb is 5, and despite this person's doubling and more than doubling of their minute ventilation, breathing their PCO2 down to 18, the pH is still 7 flat. Unbelievable. I will say that, like, again, not surprising, and honestly, again, we're working with almost the same situation as we knew we had. Profound, metabolic acidosis. From again, now we've confirmed the suspicion of ketosis, and that will slightly, I guess, change the management. But I guess some of the labs that kind of stood out to me is, so the FOS of 5.7. I don't know, like, let me just ask, does anybody have ideas of what's causing that? Because I don't know, would you have guessed in a heavy drinker who consumes a phosphaturic substance and also has a reduced intake of phosphate with a normal creatinine, that the FOS would be 5.7?
Yeah, the 2 thoughts I had seeing that, because I was surprised. I thought the FOS was going to be at best normal or very low. He has more renal dysfunction than we realize. This guy with chronic malnourishment, I mean, maybe his baseline creatinine is 0.3. Still, I don't know if that's quite enough to limit his clearance to elevate his FOS to 5.7, but is there an element of kidney injury actually? And then is the FOS, if the issue isn't clearance, but generation, right? Is this being released from cells? We know he's not breaking muscle cells down with the normal CK, which is such a valuable thing to have. But I think a quick reflex here is, even in the absence of very clear parameters of other tumor lysis syndrome, getting a uric acid and LDH, I think would be kind of early triggers on my mind when I see an unexpectedly high phos, someone who's quite sick and we don't know why, to make sure it's not from cells of who knows what type lysing open. So my quick instinct would be add on an LDH, add on a uric acid to better understand that picture.
Wouldn't want to miss that. My theory is that it's all transcellular shift. So the way we get ketosis, whether diabetic ketoacidosis or starvation ketosis, is that there's no insulin activity. That's what suppresses ketogenesis, and the fact that we are ketotic in a setting of sort of starvation and this could be ethanol-induced sort of metabolic shifting ketoacidosis, but so insulin puts phosphate into cells. And the other thing that causes an intracellular shift of phosphate, it's actually the same as potassium. It's insulin, and then alkalosis. So in acidosis, you have a relative shift of potassium and phosphate out of cells. And my guess is that once that's probably why the phosphate is high. And the reason I think that might be a triviality, but then we go to the potassium and we see that it's 3.4.
It's going to bottom out.
Yeah, and you should expect that potassium to be higher. And I think what that reflects is a profound total body and intracellular potassium depletion that I think once you correct the acidosis and give some dextrose, which will generate endogenous insulin, I think that potassium will fall dangerously into the twos.
Yeah. Hot off the press, the upper limit of normal that Maddie gave us for their beta hydroxybutyrate is 2.8. So we have 20 times the upper limit of normal ketone.
What? Wow, this may be the most metabolically deranged patients, at least in terms of acid base that I've ever heard about. Anyway, those are kind of my, I think, main actionable thoughts so far. I think the other thing that just sort of surprised me was the alk phos of 300. The AST ALT from the drinking fine, but I don't know why his alk phos is 300, but it also doesn't matter right now. It'll matter tomorrow maybe, or the next day when all this other acutely life-threatening stuff is better. But I just wouldn't expect just from ethanol effect alk phos to be that high. And then finally, the lactate from 19 to 16 after 2 liters. I just want to make it clear that that is just the denominator. We haven't improved the lactic acidosis, right? Like Maddie, I don't know if you have the hemoglobin after the patient received 2 liters from 14 to.
The hemoglobin with fluid resuscitation went to 10.7.
Okay, so you had X molecules of hemoglobin, and then the denominator was whatever serum volume this patient had. You increased the denominator, the serum volume with fluid, and the hemoglobin went down. Same thing happened with the lactate, and same thing will happen with every other concentration that we measure in the blood. So don't overinterpret certain trends in creatinine and lactate with fluid resuscitation as sort of a change in a process of perfusion or renal function or whatever. Realize that everything gets diluted, just like blood cells do.
I think the only other comment I'll make is this is a very appropriate ICU consult. Now that might be funny. Zaven just chuckled, but it depends on the hospital, depends on the resources, where we often associate ICU care with hemodynamic instability or respiratory instability. Luckily, that's not evolving here yet. But this just sheer amount of intervention and lab checks and potentially drips that this person is going to need cannot be done in an adequate way on a floor level. And so I think I love that you're bringing this case, Maddie, for many reasons, but just a great example of some of the primary, profoundly dangerous metabolic derangements that require intensive care.
Can we, I guess, I want to hear the next aliquot. Maddie, do you think it's okay if we just spend a minute just like talk about like what would y'all do for this patient other than fluids, which I think were appropriate? What else do we need to give this patient like Nowski? Anything? Do, 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 do. Steph, what would you order?
Um, I would volume resuscitate to euvolemia. I wouldn't overdo it thinking that the lactate is going to go away. So would volume resuscitate to euvolemia. Yes, thank you for mentioning glucose. Whatever the glucose is, I have a feeling that part of the fluids, besides kind of any intravascular volume resuscitation with isotonic fluid, this gentleman probably needs dextrose containing fluids, because I think that ketosis, assuming we don't have wild DKA with a new diagnosis of diabetes here, is going to be starvation and alcohol mitigated. And so giving him a dextrose source is going to be important. He needs potassium now, because as we improve his acidosis, as insulin endogenously starts being produced again, his K is going to plummet into dangerous levels. So very rapidly resuscitate him now. Yet another great reason to have him in the ICU. And I would start giving this guy high dose IV thiamine, 500 milligrams IV 3 times a day now for potential thiamine component of the lactic acidosis, potential encephalopathy, Wernicke's, because of his just slightly altered mental status. That plus his malnutrition is enough to worry about that. And so that high dose of IV thiamine IV, because we can't trust it to get through the gut, 500 milligrams instead of another dose, is because we want to bathe his CNS, all his neurons in it, and TID because the half-life of thiamine is very short. It's about an hour and a half, and we want his body bathed in thiamine all day. So isotonic fluids to resuscitate him, D5 containing fluids, rapid potassium repletion, high dose IV thiamine, close monitoring for alcohol withdrawal. As that evolves, that will also very much change his acid-base status. He'll get catecholamine surge. He'll get more tachypnic. Think I'm missing anything here?
No, I think that's what he needs. And then like once any and all of those things are initiated, like I would literally be getting repeat labs on this patient every like 1 hour initially, just looking at that potassium and pH and everything. And I think the other thing I would caution against is in this hyperacute situation, like over treating any suspicion of alcohol withdrawal with benzos and over treating any pain, specifically with opioids, because he needs that PCO2 of 18. If anything gets in the way of him, if his respiratory compensation, like, if you give 2 milligrams of lorazepam, or if you give 4 of morphine or something, if he has pain, which I'm sure he does, whatever, like if that PCO2 goes to 35, his pH is 6.8 and he codes. Like it could, he could decompensate very quickly again from that aspect, from his electrolytes jumping around. So I think really, really close monitoring both vital signs, bedside, and with labs.
Yeah, phenomenal discussion. And we were thinking the same lines as you were. And just to be kind of authentic of how the case unfolded. So on top of the anion gap metabolic acidosis, when we were called, there was also initially a concern for a potential GI bleed, given the dark substance around the patient's mouth. Actually, when EMS like picked him up from his house, when reading through the notes, they had like written in their notes like, "Oh, is this coffee ground emesis?" So that was actually part of, I think they called us, the lactate, this high anion gap, and also like potential like coffee ground emesis. So before, I had actually even come down, I think GI had already been consulted in the ED for that question. And so they got some imaging of the abdomen. They got a CTA, abdomen and pelvis with contrast. that did not show any active bleeding, but it commented on extensive small and large bowel enteritis with relative areas of sparing in the transverse colon and mid-small bowel. And it commented on a moderate circumferential fluid-filled esophagus and dilated fluid-filled stomach. Commented on a fatty liver and hepatomegaly. And they also got a right upper quadrant ultrasound that showed us enlarged and steatotic liver without like capsular nodularity. So given those imaging findings, GI recommended an NG tube for decompression of this moderate fluid-filled esophagus and stomach and started him on a PPI. He, as I kind of mentioned his hemoglobin was actually never low, and even with giving fluids, like the lowest it went was 7. And so given that he was tachycardic, but he remained hemodynamically stable and there was no evidence of brisk bleeding, they did not do an EGD, and they recommended send some infectious workup for these findings. So we placed an NG tube, and for all the reasons you mentioned, we're planning for volume resuscitation, electrolyte repletion, but given that the concern for patients, basically starvation ketosis, we're cautious about kind of introducing too much diet too quickly. So we placed an NG tube, and immediately there was some dark brown output that was not bloody, but appeared similar to stool. So our team was concerned was this emesis of fecal material, basically. So he was started on fluid resuscitation with D5, thiamine, multivitamin. And then just maybe for the sake of time, I'll just go through kind of all the data I have. So in terms of kind of the hospital course, so with fluid resuscitation, thiamine, multivitamin, his lactate downtrended. Initially it was 19, as I mentioned. After 2 liters, it was 16. We were checking the labs often, as you said, very, very frequently, and it ultimately came down to 2. And overnight, so I admitted him in the afternoon, and the next morning I was kind of looking at the overnight events. So overnight, his FOS dropped critically low to less than 0.3. It was repleted to the normal range. Overnight, the magnesium also dropped critically low to 0.9. It was repleted. His anion gap ultimately closed to normal at 9. And as I mentioned, with the fluid resuscitation, there was no, the hemoglobin was normal and no evidence of bleeding. And for that imaging findings on CT, so an infectious workup was sent. So a stool PCR was negative, an H. pylori stool was negative. They also sent a fecal calprotectin, which didn't come back when I was still on service, but I was looking through his chart preparing for this, and it ended up becoming elevated to 990. And I'll pause there.
I think you're just making great teaching points in this case, emphasizing the profound drops in the electrolytes, and kudos to Zaven for recognizing that hyperphos was very transient. I think something that's so important for people to walk away from this case with is well discussed. There was a New England Journal of Review article on electrolyte abnormalities in chronic heavy alcohol use. And this is a very typical pattern of someone coming in with alcohol-related complications with, on the point of admission, acidosis for various reasons, and a profound drop in K, phos, mag, calcium included because of the hypomag on hospital day 2, 3 is very, very commonly seen. And I'll be curious to hear, Maddie, how long it took for this dye to get back into the normal range. The profound drops usually persist and persist because the chronic alcohol use actually causes a renal tubulopathy. And even once they stop using alcohol, the tubules are damaged and dumping all of those electrolytes that you're working to replete. So just a very, very, very great learning case for emphasizing the hospital day 2, 3 profound drops in those electrolytes that you guys worked on. The bowel dilation, I was surprised that calprotectin eventually came back high. This person is a very, very high risk for just profound ileus with the amount of hypokalemia, hypophos, or critical electrolytes for gut and smooth muscle motility. So my initial thought would have been that he was suffering from an ileus from that profound electrolyte disarray. But with the high calprotectin, right? Just wondering about underlying gut inflammation, risk for fistulization, if in fact that was stool. I don't know if he ended up getting kind of more advanced imaging or scopes later on, but this is the type of person who gets ileus, critically ill, profound electrolyte disarray. To me, that's a potential explanation for just total smooth muscle gut dilation everywhere. Other thoughts you have?
I don't know. I think just looking back, like when I sort of paused and said, okay, management decisions, right? RX before DX, as you know, we like to say, or as it likes to say. Um, maybe I glossed over the dried stuff on the lips, and shouldn't have. I just kind of forgot in a moment. But yeah, absolutely. I think when you see that, you know, GI bleeding is so scary because you don't see it, right? It's sort of internal and into a very high capacitance space where people can just exsanguinate. So I think it would have been really appropriate at that point to like also frame the list of problems as, you know, possible GI bleed. Again, can potentially in the background, not necessarily accounting for all of the above by any means, but to make sure that you have, you know, whatever the appropriate management and monitoring for that as well. It seems like that never, I don't know, you're maybe going to give us the endoscopic results later, but it seems like that never sort of panned out super clinically in terms of there being a kind of very like large volume, either overt or based on hemoglobin trends, kind of large volume bleed. But I think just more broadly, in terms of those imaging findings, I actually wouldn't overinterpret them. I think I think it's just so common and non-specific to see bowel wall thickening, and you know, there's a great sort of CPS schema mnemonic of you know, of the four. I think there's four I's of not just infection, inflammation, ischemia, infiltration, but also just like edema, edema, edema. I don't know. You can misspell that to make it fit, but and anyway, this patient isn't necessarily, you know, potentially his future self, hopefully not, of having decompensated cirrhosis and anasarca and bowel wall edema and portal hypertension. That's seen very commonly, right? But again, going back to what I said about sort of the enterotoxicity, the mucosal enterotoxicity of ethanol, especially concentrated ethanol, especially at high sustained doses. I just think it's so common for people who drink heavily like him to just have chronic diarrhea and, you know, esophagitis and gastritis, and like all of that is just sort of direct toxic effects that in this case I would probably again focus on the metabolic stuff, keep an eye on the GI stuff. Hopefully there will be a period of either observed abstinence or outpatient abstinence in a, you know, high intensity residential treatment program, whatever this patient is amenable to then be able to say, okay, now that we have subtracted a handle of vodka every 2 days from your system, you know, how's your belly clinically? And then if needed, how's your belly radiographically? And then sort of start thinking about IBD or whatever else you might be thinking about right now. Cause I don't know, I feel like my sense is that that's not going to pan out.
Yeah, absolutely. And you're absolutely right that the focus was the kind of electrolyte disturbances, the evidence of refeeding, the anti-gut metabolic acidosis, and this was kind of like the problem lower further down on the list, but kind of ended up when he first came to the ED, the question was like, oh, is this a GI bleed? So we were still kind of following that line of the problem. But exactly, ultimately, you know, he never had brisk bleeding. His hemoglobin was never dropped, and so he actually never got a scope inpatient. The GI said, you know, follow up with us as an outpatient, get an EGD and colonoscopy, and especially when the fecal calprotectin came back elevated, like, you know, we can evaluate for an inflammatory process. I see that he still hasn't gotten the EGD and colonoscopy. I saw this patient back in November, but that was the plan back in November. In terms of how the patient did, so we basically just like gave him fluids, monitored his electrolytes, gave him thiamine, replaced his electrolytes as needed, and he, you know, actually improved quite quickly. I think he ended up staying in the hospital with us for about 3 days or so, but his, he never had a very altered mental status, but he became much more kind of alert and awake. His like belly pain got better. All his electrolytes stabilized. So just kind of that first night where he had really severe, evidence of refeeding, the low mag and the low phos, but it kind of like stabilized pretty quickly. We connected him with the addiction counseling team, so he was kind of connected with services for that. But ultimately he improved and his electrolytes stabilized within the first like day or so. Um, so yeah, ultimately how we were thinking about this case was, an anion gap metabolic acidosis due to both starvation and alcohol ketoacidosis. And of course, the lactic acidosis contributing to that anion gap. I love your breakdown of kind of type A and type B, and we were thinking that it was predominantly type B, given the alcohol, concern for thiamine deficiency. We want to make sure this wasn't type A and tissue ischemia. I think we were talking about, does this imaging finding of the like small and large bowel enteritis, like could that represent hypoperfusion? So I think that's still maybe kind of a question in our mind. Was there some type of like poor perfusion to the gut? But ultimately, I think, Zavan, I really appreciate your point of like maybe not over interpreting that, and between kind of having an ileus from the electrolyte abnormalities and just the severe alcohol consumption that could explain that. But yeah, overall, that's how we were putting the case together. Of course, his hospital course was complicated by refeeding syndrome. And yeah, that was the case.
Incredible case.
Thank you, Maddie. Thanks for being awake during what should be your sleeping hours on this rotation to share it. Really amazing discussion and a lot to learn from it.
I can just add a couple more thoughts. One element of severe thiamine deficiency that we didn't mention is that there can be a profound cardiovascular effect. We're sort of implicating severe lactic acidosis, anaerobic metabolism, right, from thiamine deficiency that is happening systemically. But the heart is one of the sort of tissue beds and organs that most uses oxygen, right? Over extracts oxygen from the hemoglobin in order to just continuously do this incredibly nonstop aerobic work of constantly pumping. And severe thiamine deficiency can cause like acute kind of dilated cardiomyopathy, both through a mechanism of sort of vasodilation and high output, but also just myocardial dysfunction from inadequate metabolism. In fact, I forget which one it was. It was maybe in like the early teens or 20s of the RLR series on RLR CP solvers, but Robbie presented a beautiful case where I think the patient had a documented EF of like 20%. And then after receiving IV thiamine, like 2 days later, the EF was like 60%. So looking at that patient's combination of tachycardia and non-hypertension, especially maybe in the early kind of post-alcohol, like when he still had a positive ethanol, very elevated ethanol level at presentation, was that really withdrawal? I mean, acidosis itself is vasodilatory, so that could have been compensatory, but it's also possible that, again, when he came, I don't know if he had an echo or a POCUS, whatever, like that he could have had, sort of cardiomyopathy, cardiac dysfunction as well, accounting for that significant tachycardia, and not just sort of vasodilation and compensation from ethanol effects, from acidosis effects, et cetera. Anyway, so worry about the heart too when you have severe thiamine deficiency. And if your starting point is a heart problem, also consider whether a patient may have a risk of thiamine deficiency and treat that too. So that was one point. The other one is, if I were this patient, I would actually ask that my fecal calprotectin plus minus abdominal imaging be repeated before I had an invasive procedure, a colonoscopy. And I wouldn't be surprised if those things actually resolved, again, at least in the setting of abstinence again. But anyway, that was my other kind of opinion on that. Wow. Okay, was it Harry or Sasan doing the teaching points? If you want to kind of summarize what stood out to you from the case.
Sure. Awesome
Harry?
case. Great discussion. Just very quickly, we talked about a lot about anion gap metabolic acidoses. We talked about the gold mark mnemonic, which is glycols, Tylenol, metabolite of oxyproline, lactate, D-lactate, methanol, aspirin, renal dysfunction, and ketosis. Briefly talked about the symptoms of acidosis, which are pretty nonspecific, but marked tachypnea, and some symptoms of alkalosis, which are dizziness, lightheadedness, and then weakness due to ionized hypocalcemia. We also spent some time talking about lactic acidosis. So there are two types. You typically think about type A in the hospital, shock, regional tissue ischemia from either mesenteric ischemia, necrotizing infections, or hypoxia, or type B, lactic acidosis, which is our case here, which can be from mitochondrial dysfunction, from toxins, medications, as well as impaired clearance from liver disease, renal dysfunction, and malignancy due to high amounts of anaerobic metabolism and cell turnover, as well as thiamine deficiency. Then we talked about ketosis. We tend to only measure BHB in the hospital, but we always have to remember there are other ketones that can contribute to our anion gap. And generally, the treatment for ketosis is monitor the fluid status, fluid resuscitation plus or minus glucose, monitor electrolytes, particularly with starvation ketosis, but any ketosis as well, due to the risk of refeeding. And then give thiamine and then consider insulin if you're in the DKA picture. And then we talked about a bit about hyperphosphatemia. Our differential for that is briefly cell turnover, renal dysfunction, and then transcellular shifts from acidosis. So this is what our patient had. But of course, they're also at risk of hypophosphatemia as well. Then we talked briefly about bowel wall thickening, the four I's of infection, inflammatory, ischemia, infiltrative, and edema. And then thiamine deficiency briefly can also affect the heart disproportionately so due to the high amounts of metabolism required. It can present as a dilated cardiomyopathy or high output heart failure. That's all I got for you.
Great summary, Harry. Awesome case, Maddie. Yeah, so much fun. I think metabolic disarray is probably one of my favorite
chief
problems
effects,
to
yeah.
work through. So thanks for making us an even better day.
And Harry, I want to acknowledge that whenever Steph and I discuss, I feel like there's two of us. We're often going on tangents. It's very chaotic and random. So I always feel for whoever's doing the teaching points on our on our cases. So thanks for just distilling some really great takeaways and sharing them with us. Maddie, this was such a fun case. Thank you. Go get some rest. It's awesome. Thanks for scribing, everybody. Thanks for joining and participating in the chat. Hope you all have a great rest of your week.
Bye, everyone. See you soon.
Bye.